The topic that you're voting now is, can we de-escalate axillary surgery in patients with minimal residual disease in lymph nodes in the absence of evidence? So who will be stopping the voting? I think you can say that stop now and we can have it on the screen. Okay, all right. So Andreas will be the pro this time. So they're changing the role. And Thorsten will be the against. So we will first hear Andreas's talk about his opinion about de-escalation axillary surgery in patients with minimal residual disease. Yeah, this time. Yeah, you're in the favorite position. Now, Giuseppe, would you like to say a few words about this?
No, please, let's start.
So any comments?
Yes, the comment, can we de-escalate axillary surgery in patients with minimal residual disease in lymph nodes in the absence of evidence? Yes, 31 is not a percentage, but it is clearly the majority of the poll. Yes.
Three times more, okay.
Yeah, yes.
So what I just need to do is to not lose.
Yeah, of course.
Okay.
It's a little bit tricky, you know.
Okay. Yeah, well, these are my disclosure. Again,
Can we see the presentation?
what is the question? So I'm just looking into what do we mean by minimal residual disease and what does in the absence of evidence mean. And again, we need to be able to kind of get on what the evidence and what biology tells us. Again, this is how things look like. PST and adjuvant systemic therapy have the same survival. PST enables immunotherapy benefit. It will allow for adjuvant treatment selection and sometimes de-escalation of treatments. Now, the pitfalls. We know that the classification of submicro or ITC, micro and macrometastases have been arbitrarily used in the context of post-neoadjuvant treatments, but they have not been validated in the same manner. So calling something an ITC after neoadjuvant treatment is not actually the same thing with the ITC. It is descriptively the same in terms of size or number of cells, but we have not validated the pathological importance of that. And that would have been important, but it's not. And I'll show you why. So, we are discussing that the rationale for completion axillary lymph node dissection in these patients is that it is disease that is treatment resistant, and there are some retrospective case series. The one that has been most in fashion is one from Tracy Moore, we first author for 10 years ago at the Annals of Surgical Oncology, that said that if you have one ITC, then this is the risk of extra nodes. If you have a micrometastasis, this is the risk of extra nodes. If you have a macrometastasis, this is the risk of extra nodes that are positive during completion axillary dissection. But I have some arguments with that. So let's remember that the overall survival after PST is the overall survival after adjuvant chemotherapy. We know that, okay? And we have approximately 7 big randomized control trials that looked into the effect of these patients getting no completion axillary lymph node dissection, rather going for axillary radiotherapy in those cases, the majority of which were ER positive, HER2 negative. And actually that was one of the criticisms of the trials in the beginning, right? That you did not have many aggressive subtypes. Okay. Now, what we did is that we skipped axillary lymph node dissection on these patients. We gave adjuvant systemic therapy and radiotherapy, and nobody minded about that, despite the fact that the majority of these patients had the subtype that we know from the EU breast meta-analysis on nodal path CR had the lowest nodal path CR rates. So these were the patients in which we had the highest probability of having chemo-resistant disease after the completion of radiotherapy and chemotherapy. Now, for treatment guidance, well, in upfront surgery, one post-hoc analysis of the CENOMAC trial showed that completion ALND is not beneficial, and they found that in order to find one more patient that would fit the criteria for abemaciclib, they would have to do 13 axillary clearances. And there is a recent Axana publication for which I calculated the numbers needed to treat, and that would be 12. So you could argue that they are approximately the same. The authors of the Xenomac concluded that it is not worth doing axillary clearances to prevent one event, because that would need 108 patients if you multiply. So similarly, this is the same case for the patients in post-neoadjuvant treatment, because your guidance is enough from that one procedure, which is your TAD or your sentinel lymph node biopsy, as the Axana paper tells us. And absence of data, well, take a look at that. So what you see on the left of the screen is the ICAROS study, which was, when it came out, the best available level of evidence. And since I have discussed with my opponent that neither him or myself are very content with just the best available and we would like a little bit more, the other graph over here is a post hoc analysis of the NSABP B40 and B41, which are randomized trials, and in which we see that axillary lymph node dissection in positivity played no role. It was actually only axillary radiotherapy that played a role in improving outcomes for these patients. Apart from this data, there is a little bit more data. There is actually a meta-analysis that does not show any difference, both for overall survival or DFS per se. And well, we already discussed what an YPN plus patient actually needs. They will need guided adjuvant systemic treatments. They will most often need RNI. And what we also need to consider in front of this debate is that the mysterious person behind the EU breast nodal PCR rates meta-analysis, the Xenomac post hoc analysis, and the Axana paper, as well as the person who through the EU breast has supported the ICAROS study, is my opponent. Thank you.
Oh, thank you. Thank you very much, Andreas. Now, the very difficult thing is for Thorsten to defend the no side. So, Professor Kuhn, the stage is yours. The person behind. We can listen to the person behind.
You're muted, Thorsten. You hear us, Thorsten? You're muted.
Yes, I can hear you.
Okay, perfect.
I have to share my screen now, so I've got to set. Okay, thank you. Can you hear and see me and see my slides?
Excellently.
Okay, perfect. So thank you very much, Giuseppe. Hi, Bahadir. So this is indeed difficult, and I won't try to convince the audience this time. I couldn't convince to de-escalate, but to escalate. And as you may have seen from the picture from Andreas' last slide, I was a bit younger, and now older and wiser, and therefore I want to convince you why you cannot de-escalate in low-volume metastasis. So, Oops, there's something goes wrong. I have to do this one. Oops. What is the problem? Okay, these are my disclosures. So let's start with some definitions. So according to the AGC and UICC, isolated tumor cells, PN0I+ are defined as single cells or clusters less than 0.2 millimeters or less than 200 tumor cells in a single lymph node cross-section. It is usually detected by immunohistochemistry, and there's no evidence of metastatic activity, tissue destruction. So this definition relates to the upfront surgery situation, not treated priorly. Micrometastases are defined as lymph node metastases larger than 0.2 millimeters and less than 2 millimeters. So low volume central lymph node involvement in the upfront surgery setting, we know, and this relates to studies 20 years ago that for patients in the upfront surgery setting with isolated tumor cells, 12% of these patients have additional nodal involvement, 18% of patients with micrometastasis have additional involvement. However, we have learned from the MIRROR and the IBCSG 2302-01 study that under the condition of adequate multidisciplinary treatment, low volume central lymph node involvement can be neglected. So the MIRROR study showed that patients with isolated tumor cells and micrometastasis had a worse prognosis, but when they underwent adequate systemic treatment, this difference in recurrences was equalized, and the IBCSG 2301 showed that for patients with isolated tumor cells in the central lymph node and micrometastasis, radiotherapy or X-ray dissection was not required. So can we translate the clinical significance of low-volume central lymph node involvement to the neoadjuvant setting? And we have to say, no, we can't. So this is a recommendation from 2015 from the big NABC, recommendations for standardized pathological characterization of residual disease in the neoadjuvant setting, and it was clearly stated by pathologists that isolated tumor cells in lymph nodes after neoadjuvant chemotherapy are not considered PCR. So they are considered invasive disease. So in contrast to the upfront surgery setting, isolated tumor cells after neoadjuvant chemotherapy are considered invasive disease. And about additional nodal involvement when a central or target lymph node has a micrometastasis or isolated tumor cells, and these are data from the AXANA study. These are data from the upfront surgery setting, and we have learned that patients with I+ have additional nodal involvement in 12% and micrometastasis in 18%. However, in patients who undergo central lymph node biopsy after primary systemic treatment, these patients have additional nodes in 17% for isolated tumor cells and as high as 59% in micrometastasis. We then looked in the AXANA study, how does this relate to the upgrade of end stage? And what we found was that for patients with isolated tumor cells, an upgrade from YPN0 to YPN1 was found in 6.2%. And in patients with micrometastasis, 17% converted to YPN1 and 11% even converted to YPN2 and 1 patients converted to YPN3. This is a patient from Stephanie Wong from 2019 showing the prognostic significance of low volume metastasis. And it was shown the yellow lines are isolated tumor cells, the green lines are micrometastasis, the orange lines are macrometastasis, and the blue line is negative lymph node. And it was shown that residual disease, even for volume metastasis in the CN1 and CN0 and CN1 setting, was very similar in prognosis compared to YCN1 patients. So another study showed in a retrospective analysis, in these studies, patients were analyzed who had micrometastasis in the central lymph node, and one cohort underwent axial lymph node dissection, the other cohort had only central lymph node biopsy, and it was shown that patients who had only central lymph node biopsy in this cohort, which was certainly retrospective, which did not include high patients' numbers, but the conclusion of the authors was that additional axial lymph node dissection may be warranted to confirm axial nodal status in patients with YPN1 micrometastasis. And this is a very important thing that we have to consider. The assessment of low volume metastasis, and I think Andreas already pointed out this very important issue. We have no standardized assessment and definition of isolated tumor cells or micrometastasis. There are different measurements. According to the AJCC 8th edition, the size of the largest continuous focus of residual carcinoma is included for the classification, and treatment-associated fibrosis is not included. So you can see here, it's the cluster B, and the distance A is used for categorization. According to the residual cancer burden that is used by many pathologists, the largest metastatic extent from tumor cell to tumor cell, including intervening fibrosis and extracapsular extension, is used for classification. So in the same patient, this cluster can be classified in one category or another category. So depending on the definition and histopathologic workup, isolated tumor cells or micrometastasis can be classified as YPN0I+, YPN1 micro, or even YPN1. So YPN1I+ and YPN1 micro are not reliable categories. So in contrast to the upfront surgery setting, patients with YPN0I+ and micrometastasis, they are resistant to systemic treatment. They are considered invasive nodal disease. The categorization as low volume metastasis may be misleading. They have a twofold higher additional nodal burden. They have a worse prognosis compared to YPN0, and they have a worse prognosis compared to patients that undergo axial lymph node dissection. So in conclusion, regional treatment, radiotherapy or surgery, appears indispensable. Surgery provides additional information on the final end stage. And so far, we have no data comparing radios to surgery after neoadjuvant chemotherapy and residual disease. We all wait for the Alliance 11202 trial. So therefore, my conclusion would be that surgery has still a place in the treatment of these patients. Thank you very much.
Thank you very much, Thorsten. So we heard two speakers between different opinions. So we are now for the poll again, for the voting. So can we put the score code on the screen now? Let's see first the results, and then we may have some comments and questions from the audience.
Yes. Yeah, there is an improvement now. But you still win, Andreas. Okay, so Thorsten and Andreas, I have a couple of quick comments for you. The first one is about the patient's perspective. So I think that you both realize that deciding in such a gray area between doing an axillary section or doing sentinel or stopping at certain lymph node biopsy is something very complex. And I think that we have to highlight to the patient that an axillary section is not giving lymphedema in 100% of the cases, first of all. Second, if you are going to do an axillary section in this setting, we are not going to do nowadays devastating axillary surgery with exposing the vein, destroying the nerves, and cutting whatever you find in the axillary field. And maybe one of these patients may say, I want to be in the 12 that have no benefit from having an axillary section. And the second thing is that some of these patients, not all these patients, by the time in the sentinel node biopsy they have residual disease, they are still in the middle of a treatment. So what is resistant disease at the time of surgery may be sensitive to further treatment like adjuvant, post-neoadjuvant, or radiation therapy, or whatever. So I want to see your point of view on these two aspects. Yes, please start, Thorsten. Yes.
Okay. Well, first of all, let me please. So I was considered to discuss for axial dissection, but this is certainly not what I really mean. And Andreas was quite right. I published exactly the opposite. So this is. But I think what I show, and I tried to show it on the slides, I think that we need regional treatment. But this regional treatment must not necessarily be axial dissection, which is associated with high morbidity. So what we showed in the Axana study that we recently published is that we do not have any diagnostic benefit from performing axial dissection. You know, we perform axial dissection for two reasons. Diagnostic, may be therapeutic. And we do not have diagnostic benefit. And we most probably do not have therapeutic benefit. And therefore, I think that I would increasingly abandon axial dissection of these patients because we neither have advantage for diagnostic and probably not for treatment. We wait for Alliance trial, but probably not.
Yes, so Andreas, your point of view. Can you concentrate on my second question? So what is the evidence about the effects of further treatment, further adjuvant treatment in this specific setting?
Very defining. I mean, acknowledging this is something that I saved for the discussion. If you look at NSABP 51, they considered ITCs, despite those limitations, as node negative, and those patients did not even get irradiated. And what we see is that not much happened. And if you look at the Turkish data, because there have been some sub-reports prior to the paper in JAMA Surgery, you see that not much happens, even in the setting where you have done a sentinel lymph node biopsy with a single tracer. Not much happens in terms of, time to event outcomes. So that means that it is response and systemic treatments. We are an intermediary. Now, the big question for me, just to comment on your position about that woman wanting to be one of the 12, I personally believe that the Alliance will not give an answer to that. The ATNEC will, probably. But if we find that in this setting, axillary clearance and radiotherapy are interchangeable treatments, then you will have an answer to all of that. And yes, I agree. We now routinely do axillary reverse mapping. We do not hack and slash in the axilla. We know more than to just go and hack and slash and to perform a user-friendly axillary dissection in these patients. So what I'm just saying is that it continues to feel like there is no difference by going through a more morbid procedure. And I'm not concerned about some of the studies that Torsten showed, like the Wong paper or the MSKCC paper, because all these were series that published earlier than Catherine, which was the first defining trial with the creatics, showed that guidance of therapeutic decisions is what makes a difference. We now have data from Karolinska that shows that even patients that do not have a complete pathological response, but the Ki-67 has halved, do as well as patients that have PathCR. So I think that the future is not looking towards doing more surgery, because we know since the NSABP 04, which was published again when I was 2 years old, and I'm not 2 years old anymore, unfortunately, that not many differences or many benefits are harvested from axillary lymph node dissection. The only thing that we need to be aware of is that we do not need to demonize the procedure. That's the only thing for me.
Okay, so we may take few comments from the ground, because we'll be going to the coffee break, right? Yeah, okay. Maybe 1 or 2 questions or comments. If not, we may go straight to the coffee break. So we're on time. Thank you very much.